Hello everyone, and welcome back to ER Mentorship Hub. Today, we're diving into the heart of ECG interpretation, where each line and wave can tell us a story about our patient's cardiac health. Let's get started. We're presented with a fascinating case, a 65-year-old gentleman with a now facing new symptoms of cough and fever. As we unfold the mysteries of his ECG, we're reminded of how respiratory conditions like emphysema can intertwine with the cardiovascular system. First, let's talk about the differential. When a patient with lung disease presents with these symptoms, we consider to chronic stress. Could there be a strain pattern? Perhaps signs of right heart overload? The ECG is our map to these answers. Performing an ECG, electrocardiogram, for a 65-year-old patient with a history of emphysema who presents with cough and fever is clinically reasons. 1. Assessment of cardiac status. Patients with chronic lung diseases, such as emphysema, are at increased risk of developing heart complications like cor pulmonale, right heart failure due to lung disease, pulmonary hypertension, and arrhythmias. An ECG can help assess the heart status and detect hypertrophy caused by these conditions. 2. Detection of arrhythmias. The symptoms of cough and fever could be related to an underlying infection, which can lead to an increased sympathetic state or direct myocardial irritation. This can cause arrhythmias, which would be evident. 3. Monitoring of drug effects. Certain medications used to treat respiratory conditions can affect the heart rhythm and function. For example, bronchodilators like beta agonists can cause tachycardia and other arrhythmias. 4. Baseline information. The patient requires treatment that could affect the heart, such as starting new medications or a procedure. Having a baseline ECG is valuable for comparison in the future. 5. Exclusion of cardiac causes of symptoms. Symptoms, such as cough and fever, could also be atypical present events, especially in older adults. Conditions like myocardial infarction can sometimes present without the classic chest pain and may mimic respiratory issues. 6. Evaluation for infection effects. Systemic infections can impact the heart, leading to myocarditis, pericarditis, or exacerbation heart conditions. An ECG can help identify these complications early on. 7. Screening for electrolyte disturbances. Severe infections can lead to electrolyte imbalances that may affect cardiac conduction and rhythms, which would be identifiable on an ECG. Our cardiac axis. Watch as I assess lead eye and AVF. The direction of deflection gives us clues about the heart's electrical orientation. It's a window into its structural integrity. In this case, both lead 1 and AVF have a positive deflection, meaning a normal axis. Moving on to the rhythm, the signature. We'll break it down into 4 key components. 1. P-wave morphology and presence. Look closely at these tiny but mighty waves. Their shape and presence, or absence, can unravel tales of atrial activity. Notice in our ECG they are in shape with nearly every beat. This would lead us to conclude that he has multifocal atrial tachycardia. We are going to discuss it in greater detail in a few minutes. 2. P-interval. Next, the PR interval. This short span of time holds the story of atrioventricular conduction. Is it prolonged? Short? Each possibility narrows our differential. 3. QRS complex width. The QRS complex width tells us how quickly the ventricles are getting the message to contract. A wide complex might suggest a detour in the usual conduction pathways. 4. QRS complex. And finally, the regularity of the QRS complexes. Are they evenly spaced, or is there an unpredictable rhythm to their occurrence? This irregularity is the heart's Morse code, signaling us to decode further. Now, let's calculate the heart rate together. By counting the number of QRS trusty ECG paper as a guide, we determine how fast the heart is beating. A rate of 124, a tachycardia that beckons us to explore its origin. Each group of leads on the ECG grants us a different vantage point. We observe the inferior leads, then the lateral and the anterior. nonspecific T-wave flattening. These subtleties in the terrain may indicate areas of ischemia or suggest a strain pattern, a common companion to lung pathologies like emphysema. With all clues in hand, we arrive at our diagnosis: multifocal atrial tachycardia, or MAT, at a rate accompanied by left ventricular hypertrophy and those intriguing T-wave flattenings in the inferior and lateral leads. MAT's hallmark? Irregular atrial complexes of various morphologies, each with a story, each finding its way to the ventricles. Let's learn more about MAT. Multifocal M8 is characterized by multiple ectopic foci within the atria firing at an abnormally high rate, leading to a tachycardic response. The pathophysiology behind the P-wave changes observed in M8 includes the following elements. 1. Multiple ectopic foci. In MAT, there are pacemaking sites within the atria that compete with the sinoatrial SA node for control over the heart's rhythm. These sites can be triggered by a variety of factors such as hypoxemia, electrolyte imbalances, increased sympathetic tone, or underlying lung disease like COPD emphysema. 2. Irregular atrial activity. The P waves on an ECG represent atrial depolarization. In MAT, the presence of multiple atrial foci leads to depolarization from different locations within the atria at different times. This results in P waves of varying shapes, amplitudes, and directions on the ECG, reflecting the varied origin of atrial activation. 3. Variable atrial rates. Each ectopic focus can have its own intrinsic rate of firing. The heart's conduction system may respond to these impulses at a variable rate, contributing to the irregular rhythm. 4. Ineffective atrial contraction. Because the MAT is not synchronized, atrial contractions are often ineffective in propelling blood into the ventricles. This can result in varying PR intervals, and sometimes a 1:1 atrial to ventricular conduction is not maintained. 5. Autonomic influence. The autonomic exacerbate or modulate the frequency of ectopic foci discharge. For instance, increased sympathetic tone in situations like stress, hypoxia, or the use of stimulants can increase the firing rate of these foci. 6. Underlying disease states. Often, MAT is associated with conditions on the heart or lead to changes in atrial tissue, such as chronic obstructive pulmonary disease, COPD, pulmonary disease, and electrolyte disturbances. These conditions can alter the atrial myocardium and make it more susceptible to ectopic activity. In MAT, the irregularity of P-wave morphrhythm is a hallmark feature, differentiating it from the more organized atrial activity seen in conditions like atrial flutter or the disorganized activity in atrial fibrillation. The P-wave changes are indicative of the underlying chaotic electrical activity within the atria. Multiple competing atrial pacemakers creates a rapid and irregular atrial rate that can be observed on the ECG. This irregularity in the atrial activation leads to an overall irregular ventricular response, provided that the atrioventricular AV node conducts these impulses. However, it filters out some of the atrial impulses due to its refractory period, which contributes to the irregular rhythm seen in MAT. The presence of MAT on an ECG is clinically significant because it can be a marker of severe pulmonary or systemic illness. It is often seen in the context of exacerbation of lung diseases or in conditions that lead to increased atrial stretch or myocardial irritation. Therefore, the P-wave changes and irregular rhythm not only reflect the electrophysiological disturbances, but can also guide clinicians towards understanding and managing the underlying condition, causing the MAT. And there we have it, an ECG decoded, a story unveiled. Remember, each line on that paper is a glimpse into our patient's health, a narrative waiting to be told. If you've enjoyed this cardiac detective work, share your thoughts in the comments below. Don't forget to like, subscribe, and hit the bell for more ECG insights from Until next time, keep learning, keep interpreting, and stay connected.